Hello, everybody, and welcome to this afternoon's webinar. It's a real delight to see everybody here today, and thank you so much for your time. I know everybody is very stretched, but we're really excited about today's session. So yeah, really hope that you enjoy hearing from some fantastic experts about outreach teams in neonatal care. We have run an MDT spotlight for, we've done a few sessions in the same sort of format. All of those are still available on our website, and we're really pleased to be doing another session with a little gap between them, but to really focus today on, as I said, neonatal outreach teams and what they bring to that wider MDT working, thinking about family integrated care and making sure that that reaches every baby. I am just going to make sure that I can flick through these slides. Give me one moment. So yes, big welcome to you all. I am Chelsea Letts. I work at Bliss. I'm the Healthcare Engagement Programme Lead. And I will pass over to some of our fantastic experts here to introduce themselves in just a moment. But in terms of what we want to try and cover in today's session, we've got a lot to squeeze in. I'm pleased to share that a parent has kindly shared their experience for us to give you the opportunity to hear from her about her own experience with support with neonatal outreach, which I think really sums up a lot of the themes that we're actually going to be covering kind of further on in the session. I'm going to be handing over to the experts to talk to us a little bit more about what outreach services looks like, what it can look like, a bit more about the framework that's been recently produced, which I think is a hugely exciting, aspirational framework. And we'll have the opportunity to ask a few questions about everything that's covered. And then we're then going to have an opportunity to hear from a team that have led a project to do outreach in a much kind of broader MDT sense, which I think will be really exciting to hear. There will be opportunities to ask questions. Please do pop anything in the chat that we have or the Q&A function. We will try to cover as many of those as we can. We did get a few through the registration form, so again we'll try and cover those as we go. And if we can't cover them, then we will try to make sure that we do that in some other way. But yes, that's the plan for this next hour. And really the idea of doing these sessions is so that we can support as Bliss with the raising awareness of knowledge of the different services within neonatal care, and outreach is such an important part of that. We really want to try and encourage and inspire the people attending today or watching back that outreach teams can be and should be a really vital part of that wider neonatal team. And how important they are to care delivery and challenging the barriers that families face that might make the service a bit more inequitable. So there's a lot to try and cover, lots that we want to try and achieve today, but that's where we're coming from with this particular session. So this is Steph. I will play her sound, unfortunately, is quite low, so please do turn your volume up and you should be able to hear it okay. But Steph will introduce herself and then tell you a bit more about her own experience, and then we will hear from the experts. So I will pass you over to Steph.
So hello everyone, my name is Steph and I'm a proud mum to identical boys, Ralph and Hugo, and I wanted to share some of my experience with you following their time in NICU and how we came home as a family and the outreach support we received. So when we were in hospital in NICU, the boys were born at 26 weeks. And we spent 3 months overall in 2 different NICU units. And one of the big things that was a worry on my mind at that point, I really wanted to get, it was near Christmas and I longed to have the boys home for Christmas, but it seemed like a big to go from being in that hospital environment to being, and it was brilliant. We received from the NICU team in Stoke Mandeville at the time. They really prepared us for effects of what it would be like to go home. So we'd been quite involved in the care from obviously a feeding perspective. We were there every day. So we knew their feeding schedules. They were born really premature. It was really important that we were feeding them very regularly. And with two of them, making sure we were feeding both of them, not the same child twice. So from a feed, they supported us in the different medicines that would be going into their milk, and also to make sure that, because we were fortifying at that point with different things, and to make sure we were clear on the feeding pattern. And that worked really well then when we got home, because we were knew. And we kept to the structure of hospitals, and then when we got into a routine, we sort of relaxed it to work for us. Thing was, one of my sons, Hugo, was on oxygen, so that was obviously quite a key for us in terms of how we would manage that at home. And at the time, it was quite a shift, because I never imagined going home with a oxygen. But the NICU team were brilliant. They helped us make sure and I were really equipped to understand how tanks, how to fit the nasal cannulas, support, put the little patches on, had all of the supplies, the materials we needed, helped us go through all of the process of doing an oxygen risk assessment, and would do things like a car seat challenge to make sure he would be safe on his oxygen in the car seat, and we knew how to fit everything. And then when we made it back home, we had a community outreach team that would come and visit us every week, make sure we support with supplies of things, and then if we had any questions about sort of life in the with obviously two still very premature boys, oxygen, they were a really good help. They also helped us, so Hugo qualified for a disabled badge, which was really useful with the first sort of term of him, because getting oxygen tanks in and out of the car and having twins and a pram, having that additional flexibility was really useful. So yeah, the team, both from the hospital side and from the community nurses, were brilliant at helping us sort of make that journey back home. I think the learnings for me, we kept our circle quite close to start with. I was quite nervous about taking two very vulnerable premature babies and one with an oxygen tank, to what I had putting in terms of your sort of mother and baby events and things like that. But with their support time, I got confident, taking them out and about on my own. And also things like National Trust became a massive venture for us, because you could put them in the pram, go for lovely long walks, and just have some nice headspace away from the house. So yeah, I hope that helps anyone going through that journey, and all the best.
So a big thank you to Steph for sharing her story. I think it's always a difficult thing to revisit, so we're always really grateful, but gives us a lovely frame for what we're going to talk about today. I actually spoke to a few parents in preparation for this, and it is universal that the transition to home is a very difficult time for families more broadly. Steph particularly spoke a bit about how grateful she was for something which probably was quite small, but having the support of staff to be able to take both her boys in together was so important to her, and staff really supported her to do that. So yeah, it's a massive thank you to everybody working in this field and who's interested in working in this field, because it does have a huge impact on families at this time. So I'm now going to hand over to Sarah Clark. Sarah, if you're happy to just quickly introduce yourself, and then it'd be great to hear a little bit more about outreach services more broadly, please.
Absolutely. Thank you, Chelsea. And massive thanks to Steph for sharing that story. Because I think when we're thinking about outreach, our parents and families and babies have to be at the heart of what we do. My name's Sarah Clark. I'm the lead dietitian for the West Midlands Perinatal Network, and by some chance happen to also be the co-chair of the Neonatal Networks Outreach Group, but I also chaired the framework in my role as the BAPAM Allied Health Professional Psychology and Pharmacy representative. So I've had a passion about outreach for some time, and I'm going to share with you just a little bit of background about how we came about the important elements within it. Let's share my slides.
Perfect, thank you, Sarah.
You got those, okay. Let me just get my okay, just need to fine, okay, cool, let's get that up. Okay, so yes, I'm going to talk to you a little bit about the background around the work that's been happening both nationally around outreach. So one of the things that is really important is for us to consider what the definition of outreach is, particularly when we're thinking about the neonatal services, because we have a lot of services that deliver hospital at home across all aspects of medicine, but neonatal outreach really hadn't had a definition until the Neonatal Networks Group really pulled together and looked at what outreach was actually going to be defined as. And we were really keen that the most important part of this was around it being delivered by neonatal experts, particularly multidisciplinary teams, that the needs of families and babies needed to be kept at the heart of everything that we did, particularly when we're looking at that transition stage from hospital to home. We were delighted to be able to support the work of the BAPM framework group. So several members of the Neonatal Networks Outreach Group, or the NNOG, were supporting the work of the Outreach Framework Group. And I was delighted to be able to chair that, co-chair that with Janine Snook, who has very rudely now moved to America. But Janine was instrumental in the setting up of the Outreach Group for NNOG, but also in supporting with the framework. And I think everyone who works in neonatal outreach really does understand that there is a real need to support families when they leave the unit. We know that the neonatal journey does not end at the door when families leave our care, and that actually often for our families, going home is probably one of the most stressful events of their neonatal journey, particularly if they're going home with babies who might have additional medical needs. So, for example, Steph talked about she talked about oxygen for a little boy, but also supporting families with tube feeding particularly is one of the basic cares that we can support with to try and get families back home together as soon as possible after they've been in neonatal units. But actually nationally and within policy, this has now become a recognised need. So it forms part of the critical care service specification, which was published in 2024. Also as part of the BAPM service and quality standards in 2022, and also neonatal outreach, particularly the expansion of neonatal outreach, was highlighted in the GIRF report that was published in 2022. So you can see that outreach really is high on the national agenda around how we move neonatal care forward now and also into the future, to be delivering that alongside families in their own home, also thinking about how that aligns with the 10-year plan for the NHS, that we should be looking at more community-based services and supporting care to be delivered where it's best for families, particularly in this case. However, what we do know is for some published research done in 2022 that actually neonatal outreach is not equitable across the NHS, particularly looking at only 72% of services had a dedicated neonatal outreach team. But what we also found from that survey is that often the elements of outreach that were delivered were also very variable. And certainly when we look at the staffing and days of operation and the range of service delivery, that is not equitable. There's no standardization around what outreach should look like and how outreach should be delivered. And lots of different ways of delivering the service have been developed, but some of them will not always meet the needs of families, particularly when we're thinking about where they might be geographically spread far apart, or where we know in some networks there's very little outreach that's actually delivered. One of the things that we were delighted to support with as part of the work with NNOG and also the BAPM framework was a survey that we did with families. We were blown away by the fact we had nearly 400 families that responded to this survey, and half of those families had actually received outreach support and half had not. But it gave us an opportunity to really drill down on what was important to families and what was what was missing when families didn't receive outreach. And you can see here from the top list of things that were important to families, actually, when you got past the bits around the baby, so health checks, growth and feeding were really high on the agenda for families, and their focus was very much about their baby. But the next thing after that was about the focus for themselves and their mental health and their well-being. And we had hundreds of comments, of free text comments throughout the survey, and many of them were around actually how families unravel when they go home, and actually that psychological support around their mental health and their well-being is just as important as supporting them with the medical care of their baby. And one of the things that we were really keen on when we developed the framework, we had a multi-professional group, which were all the people involved in the framework were fantastic and all worked really hard to create the content for the framework. But we were driven by the fact that we wanted outreach to be a multi-professional model of care. Just as we would like to see neonatal care in units, we want to see that outreach reflects that multi-professional neonatal care staff. So whilst it's a very heavily nurse-driven service delivery at this point, our aspiration is to see that extend much more multi-professionally, and we're delighted to have a couple of allied health professionals who are going to speak about the service that they've developed in their local team. And I'm going to hand over to Leslie.
Hi, can you hear me okay? My name is Leslie McGuire. I'm Community Liaison Team Leader based in the Royal Hospital for Children here in Glasgow. So I'm just going to speak a wee bit about service delivery. Through the BAPM outreach framework, we were able to outline levels of support when delivering neonatal outreach for units who do not offer outreach, starting at level 1 and offering a check-in telephone call is a massive lifeline for families to know that they have that single point of contact if any questions or concerns arise. For a lot of our families, their journey is just beginning when they leave the neonatal unit, and outreach support is so important in ensuring families are able to remain at home safely with support from a specialised team. We recognise that neonatal outreach services across the UK vary in terms of workforce, structure, models of care and scope of practice. Through the BAPM framework, we aim to address these disparities by offering clear guidance and shared standards. Currently, some of the services offered by neonatal outreach include feeding support, home oxygen, home phototherapy, growth monitoring, medicine management, wellbeing checks and specialised support for complex surgical babies, all of which help facilitate early discharge home for families, thus reducing parent and baby separation. As neonatal outreach teams, we are the bridge between hospital and home. The care we provide extends far beyond, sorry Sarah, next slide. The care that we provide extends far beyond the walls of the hospital, and the relationships we build with our families are founded on trust, compassion and respect. Supporting the transition from hospital to home takes time and highlights the importance of building early relationships with our families. Having a familiar face visiting families at home is so important, as it not only provides invaluable support for families, but also ensures continuity of care during those early days. Being present in ward rounds, understanding each baby's journey and having awareness of any issues that may arise once home is so important. We also work collaboratively with other agencies such as children's community nursing teams, health visitors and family nurses. We often look at any options available to our families to allow them to complete training such as nasogastric passing at home, aiming to reduce the amount of days spent in hospital and keeping families together. In Glasgow, we update the health visitors weekly, ensure that they are fully informed with all the details of the family's journey in the neonatal unit, and we often receive feedback from the health visitors to see how invaluable this information sharing is to them when supporting families at home. I recently attended Glasgow Caledonian University to carry out teaching on the health visiting course, as I'm often asked to explain some of the common conditions that we see in the neonatal unit. The teaching was very well received, and moving forward I'm hopeful that the neonatal care will be included in the health visiting curriculum. Next slide please. We know the profound benefits of delivering care in the home environment, not just for the child, but the whole family. Once discharged from the neonatal unit, many families will still require ongoing support from the neonatal outreach teams, and as mentioned, collaborative working alongside the health visitor, family nurse, CCN teams is vital. For complex babies, joint visits may be required. If we have a complex baby going home, I always offer the health visitor the opportunity to visit the family in the neonatal unit to allow them to see the baby pre-discharge. This works really well and gives the health visitor the opportunity to see the baby looking well and what their normal colour and appearance looks like. Some babies have cardiac conditions, tracheostomies, and this sometimes can affect their colour. I always reiterate the importance of prompt escalation if the health visitor was to visit a family and had any concerns, as we're all aware of how fragile our babies are. This is a personal child health record that's given to families across the UK, and it records important milestones such as weight, length, OFC. In Scotland, personal child health records are issued by the health visitor around day 11-12 when carrying out the first visit. It also outlines important details such as immunisations and breastfeeding. Next slide, please. Transition from neonatal outreach can be really difficult for families. We often, because we've been often in such close contact for many months and become an important part of their journey. It's therefore essential to consider organising face-to-face meetings to support handover to paediatric teams where families feel this would make the transition easier. Every family is unique. Some may feel comfortable simply receiving contact details and information, while others may benefit from meeting their point of contact in person to help build trust and reassurance. For neonatal outreach nurses, handing over patients to paediatric teams can also be challenging. Reduced staffing levels and the inability to always provide a consistent single point of contact can make continuity of care more difficult. Despite these challenges, clear communication, collaborative working and recognising the individual needs of family remain key to supporting a smooth and positive transitioning experience. Next slide.
Unmute myself as well as do the slide. So thank you very much, Leslie. One of the things that we want to think about is really where do we want to be? We know that the framework is aspirational. We know that there's lots of work going on around neonatal outreach. So when we're thinking about how we can move forward, we want to think about equity is really, really important, that actually we want to make sure that all babies across neonatal care have the access to neonatal outreach, that it's not a postcode lottery, that we know that it currently is in some areas. And not only is there equity in access, but actually equity in the service provision, so that all babies, irrespective of where they are, and all families can have the support they need to transition from that acute environment into their home environment and continue the care for their infant. And that's really important.
Brilliant. Thank you both, Sarah and Leslie, for sharing that, I think, really thorough overview. I know we could do days and days on outreach, so tricky to fit it all into 10 minutes, but thank you so much. It was a brilliant job. So I'm going to take the opportunity, I think, to just delve into some of what you shared a little bit more. Really delighted to also welcome Gaynor. Gaynor, do you want to just introduce yourself as well so everybody knows who you are?
Hi, I'm Gaynor Lovett. I'm the community neonatal team leader from East Lancashire. So we cover Blackburn, Darwin, Hyndburn, Ribble Valley. It's quite a large area. Thank
you, Gaynor. We're really delighted that you're here. I think really encouraging to hear so much of what you both shared, Sarah and Leslie, about the challenges around equity, but acknowledging that that's a real thing, and that it's really on the radar, and making sure that families' individual needs are really taken into account. It's obviously such a big transition, both when they get to home, but also when they are moved away from neonatal outreach services. So there's quite actually two big transitions there, aren't there? So there's a lot for these teams to manage. So we do have a few questions. If anybody does have any other questions that you'd like us to ask, then please do pop them into the Q&A and we'll be looking at those as we go. I think we've obviously spoken briefly about the framework, which is fantastic, but it is aspirational. I think that was also mentioned, and there are challenges in terms of kind of how that's delivered and around the inequities that we've just touched on as well. And services can obviously look very different in different units. I wonder whether, just on a practical note, you could give any advice on how services can kind of balance that ambition to kind of reach that kind of gold standard that's outlined in the framework, when outreach support just isn't really universally accessible to all families. Whether you could touch on that a little bit.
Yeah, so my advice would be for any units that are not yet offering neonatal outreach to reach out and get involved in our NNOG group. It's obviously health professionals from all different specialities, dietitians, nurses, speech and language. We all get together and share good practice, speak about outreach across the UK. It certainly opened a lot of opportunities for me joining the group. To get advice and start out or reach out to units that are offering it so that we can support you starting that journey. Start off at level 1 in the framework by offering a telephone call. That's a huge lifeline for our families to know that they've got that point of contact. So just reach out, get in touch, and we're happy to speak about what we're doing. When we wrote the BAPM framework, we wrote it like it was going to be the gold standards, that we know that that's not going to be the day-to-day running because our NHS is facing huge financial restraints, and we recognise that. But, you know, get in touch with us. We're happy to speak about it. If there's any advice, we're happy to be sharing good practice and supporting that starting for neonatal outreach.
Yeah, brilliant, Leslie. I think it's really helpful to know that there's a real community out there that's already super passionate and engaged with this as well. So there is a comment, I think, as well, which I think Sarah has responded to in the chat, but just about whether that telephone call is, you recommend it being like an active, something that you offer and you call, or whether it's a families can just get in touch with you, or whether it's a combination of both.
I think it's important to have a combination of both. Like, I think it's really important for families leaving the neonatal unit that they have a contact telephone number to phone. You know, I had a telephone call this morning about a baby that got discharged last week and having issues with reflux, and mum's phoned the GP and the GP says they won't see the baby because he's too little. So they've come back to us. So that's really, really stressful for families. So I think it's advisable to have a point of contact where they can you. Yeah, absolutely. But to know that somebody's going to be phoning in and checking on them, you know, all these little things are really, really stressful for our families. And I often find that some of the little things I can sort out in 5 minutes with a phone call or an email, but they don't have that. So that's really important to have that point of contact for our families.
Yeah, thank you, Leslie. That's really helpful. We had a question that was put through the registration form actually about some of the services looking quite different in centralising kind of how outreach looked. So it might mean that some staff can't meet the baby before they get discharged and when they might be supporting them at home. Are there any ways that you think that that could be addressed to kind of support the family more?
Was that around parental feedback?
So I think it's, I mean, I think we definitely want to pick up on parental feedback in the way that I think in the survey that you mentioned, the families really want to feel like they can speak to somebody who has an understanding of the neonatal experience, and whether, yeah, please do feel free to explain that a bit more, Gaynor. That would be great.
So yeah, I think it's really important that we hear the voices of parents and their feedback, because obviously they're at the heart of our decision making for our ongoing neonatal services to be embedded. We need the great leadership as well that's provided from the trust and feeding into the local LMNS to be given the direct voices from the parents and service users, because it obviously influences and provides continual improvements to give safe, quality and effective care. I know that we look a lot on our parent feedback forms about parental experiences and behavioural changes, we don't just do it from like an admission point of view, midway as well, through the neonatal journey and at discharge. And we also do it from a discharge perspective from the community outreach team as well. So we're getting the voices along all the stages of the neonatal journey. And like Leslie said and Sarah said previously, obviously it's understandably a very stressful time for families. There's a lot of anxiety. Anxiety and depression can come hand in hand, you know, along the neonatal journey. We do give, in our area, we give a lot of psychological support during that journey and post NICU journey as well. Dads can often get forgotten about a lot of the time. We have the Dads Matters group near us. I don't know whether other areas have that as well. We find that group very useful. We have coffee mornings as well, where we get feedback from the local MMVPs during our coffee mornings as well. Getting the parent peer group support going as well for our local services, and also the bereaved families as well, not forgetting those families that access our services.
Yeah, absolutely. There's a whole range of experiences, and trying to capture them in lots of different ways is a really sensible way forward, because I do think you're right, that feedback really shapes services, doesn't it? Thank you, Gaynor, that's really helpful. So just to go back, I think we were talking about the fact that the services might look quite different, be structured in different ways. Do you have any advice for teams who might be supporting families that they actually haven't met on the unit? We are going to talk a bit more about kind of how outreach teams might kind of work collaboratively with unit teams, but I know that that is a reality in some locations. Do you have any thoughts or advice about making that as a smooth a transition as possible? That's
so all right. Are you talking about families who like need to be repatriated, maybe?
Yeah,
those are sorts of families.
Yeah, I think there's that where yeah, I mean, I think that's definitely an example of where that's the reality. Yeah.
So it's obviously important that we're giving a consistent approach. You know, sometimes it might not always be same day repatriation. If it is, it could be like an emergency situation, but keeping the family involved as much as possible in those decisions. Like the MDT working is really important.
Yeah.
The role of the GPs, getting everybody else involved who's going to be supporting the family, social workers, you know, specialists. It might involve like the surgeons, another trust maybe. Just making sure that parents know the emergency contacts, like Leslie said, because they're obviously going to be very anxious about being transferred. Sometimes it's about educating, you know, parents, and, you know, giving them as much information as you can possibly before they are discharged or sent, you know, to another unit. I mean, this can be done over Teams sometimes, or video calls, making sure you're having, you know, individualised discharge planning meetings as well that are tailored to that family, because it might not just be medical problems. There could be psychosocial issues. I know we've had one recently. Sometimes, you know, it can be quite complex. Just making sure you've got a robust handover, really, for these families. Documenting all your plans, ensuring that you communicate and you coordinate in everything in a timely manner.
Thank you, Gaynor. That's really helpful. I think that leads us really nicely on to talking a bit more about how outreach teams can support on the unit and the role on the unit, as well as obviously supporting families at home, because there's obviously a really important connection that needs to be made between teams to ensure that that discharge and that transition to home is smooth. Can you explain a bit more from your own experience about how being engaged kind of earlier with families on the neonatal unit can help with kind of building confidence and that continuity and the trust that you just mentioned, Gaynor, for families once they leave the unit as well. Talk about that kind of work that starts before then.
So I think that's one of the most probably special parts about this job, because you are meeting the families for the very start. You know, you're meeting them obviously in the day of admission, and you're seeing how far they're coming along their journey. For a lot of our families that are maybe taking home complex surgical babies, or babies obviously requiring home oxygen, you know, you're starting that kind of teaching, building that confidence, supporting them from very, very early on, and you're building up those relationships. So that's really important, that you're meeting them from the beginning and you're part of the journey the whole way through. And also for me as a nurse, when I'm going out to visit those babies at home, I want to know what their journey is, because if I'm going out and I'm seeing something, I'm thinking, is this new, or did this happen in the hospital? Will we having issues with your passing stools? Will we having issues with constipation? Or did this wound look like this before you left? So I think it's really important for us as well as the families to be knowing what the journey is, finding out the background about the circumstances obviously at home. There could be a mum establishing feeding and she's in the family room, and you know the baby's not putting weight on, but the mum's so stressed because she's got a 2-year-old at home. So is it causing her more stress to keep her in? Can we safely put them out and pass or discharge them with a robust plan in place? So it's so important to be finding out the background circumstances of the family, and the only way you're going to find that out is getting to know them. I find so much out from actually having a conversation with the mum, the dad, the granny. That's where I find out, because stuff can get handed over but it's not always accurate. So that's really important, to be building those relationships and for them to know you, because they're welcoming you into their house. So it's as equally important for us as outreach teams to know them as what it is for them to know us. That's what I feel.
Yeah, absolutely. Thank you, Leslie. That's really helpful. It reminded me, actually, we're doing a pilot at the minute, actually, at Bliss about having those sort of conversations early. I think if we don't know what the challenges families are facing, it becomes really difficult then, doesn't it, to support them effectively. So you've just summed that up beautifully. Thank you. And I think so interested, that's kind of about the family and building relationships with them. It'd be great to touch on a bit about how outreach services can work with unit staff, with staff working on transitional care, to really support families in that discharge preparation and planning. Have you got any kind of thoughts or advice about engaging with other teams to support that?
Obviously, again, it's about working with parents as partners in care, and you know, with your FI-care approach, starting it as early as possible, so it's not coming as a surprise to them. Say if we're thinking about oxygen or thinking about tube feeding, that the parents are fully on board with that. I know from experience it comes as a massive shock to a lot of families. I know as a nurse it'd come as a massive shock to me if they said that my baby would have to go home on tube feeding or oxygen. So I think sometimes it's just putting yourself in their shoes, and getting the staff on board as well with that. Because sometimes, you know, you're asking staff to do competencies with families, and it's not just a tick box exercise. It's about, you know, looking at the whole family unit as well, because you know there are a lot of other things going on with that family a lot of the time. You know, they're splitting the time between other children or other needs. You know, there might be other things going on. They might be looking after other family members. So yeah, it is working with the staff who are caring for their families as well on the unit, or on TC as well. Sometimes, you know, we find out early on. So on our unit, we do like a preparation and planning visit, and sometimes families can open up a lot at those visits, and a lot of information can be, you know, given out to us. So it's about signposting families sometimes to earlier help. You know, maybe it might be like psychiatric help, or you know, trauma services, perinatal mental health. There's a lot of information that, you know, we're giving to these families pre-discharge, and it needs to be done in a timely manner. It shouldn't all be just done the day before discharge, which I think used to be the case.
Sure.
because it's a lot of information for people to retain, and obviously arranging like the discharge planning meetings, getting the MDT on board, you know, contacting your other allied health professionals who are going to be working with the family as well, you know, getting them on board and introducing them to the family as well if they've not already met them on the unit. I think that really helps the family, you know, picture what's going to be going on at home, and then just giving them general advice as well, you know, and recommendations, you know, from your experience about, you know, maybe for a home oxygen baby, you know, these are the sort of vaccinations that may be coming up, advice about going out and places to maybe avoid. You know, it's sometimes it's a lot of information. Sometimes we give them help with the disability living allowance forms and other sorts of forms as well. And like Leslie said, a lot of the time it might just be a simple phone call to a GP, but a lot of that relieves a parent's anxiety.
Thank you, Gaynor. That's really helpful. I think worth just picking up on what you said, that I think it feels like two really important points, other than kind of obviously the really helpful support for families and how timely that should be, but about viewing outreach teams as part of the team is so important for that seamless transition. And that it should just be an extension rather than kind of looked at as an additional service. That seems to come through for me. But also you mentioned, I think, about that partnership with parents. And I think it highlights, again, kind of looking at it holistically and through that whole journey, if that partnership with parents and supporting them to be parents in there and support them to be part of their baby's care in as many ways as possible, as early as possible, really makes that transition home easier. Because then they feel more empowered, they feel more confident in what they're doing. I think if that starts later on, it becomes really difficult kind of to build that expectation in. So I think that's a really powerful demonstration of the power of having kind of as much family integrated care kind of ethos and practices on the unit as possible will support not only them on the unit, but when they go home as well, and working with outreach teams. So thank you for sharing that. I have one more question just about kind of hospital at home approaches. I know that was briefly touched on, I think, in the slides, and how that might support with kind of bringing that family integrated care kind of ethos into the home. I don't know, Leslie, whether you're happy to pick up on what that might look like for families.
Again, it's obviously highlight the importance of building these early relationships and giving families obviously that confidence, sharing your knowledge, supporting them to be partners in their baby's care for very early on. You're not wanting to be seeing them on the day of discharge, right, here you go, when you've not prepared them. You know, it's one thing looking after a baby in here when, you know, your baby's on oxygen or your baby's maybe got a stoma or an NG tube, and then it's one thing walking out the unit with your baby in a pram with an oxygen cylinder. You know, parents will often say, I just can't wait to go home. And then for us as outreach nurses, when you go in and see them, you see, when you go home, you know, they are scared, they are frightened. It is really, you know, daunting taking your baby home. So it's about preparing them as much as possible and knowing that they do still have that support network and somebody to contact if they do have a question, if they are worried, and we're supporting them, and also preparing them as much as possible about the practicalities of taking a baby home with oxygen. You know, I can tell you a few stories about toddlers around home oxygen and pets. You know, this is real life. This is, you know, it is difficult taking your baby to a shopping centre and obviously transferring them from a car seat, and that's obviously referring them on to DLA and getting a blue badge. So it's about having those open and honest conversations about what that looks like. And sometimes you can prepare them as much as possible, but they still, obviously, it's still a shock to them. And that's even more important, reiterating the importance of that familiar face getting to see them. You know, you want somebody that you've known through your journey to be answering those questions. So it's, you know, the job that we do is so important, and those relationships, those continuity of care for us and for the families is just, it's so important.
Yeah, thank you, Leslie. I think Steph, you just reminded me something that Steph told me when we were chatting ahead of the video. She was saying a similar thing, that one of her twins was on oxygen for a much longer period of time than she was expecting. And actually that was she didn't necessarily feel like she was prepared for that and kind of what that meant. And I think, but she was I think, really reassured by the team to know that doesn't mean that it doesn't mean anything bad. It just means that your little boy just needs a bit more support, particularly overnight, she was saying. And I think that is, as you say, managing those expectations so that they are prepared as far as possible. We know that there'll be things that might crop up that are difficult to or unforeseen, but yeah, that expectation I think is really important. Thank you both so much. That was really helpful. I think we're now going to pass over to Rachel, who's going to share a bit more about a specific project in New Cross, which was an allied healthcare professional MDT project around outreach. I think Sarah kindly is going to share the slides, if I remember rightly. Rachel, do you mind just coming in at that point and introducing yourself and telling us a bit more about this project, please?
No problem. Apologies, my camera appears to have stopped working, so you'll just have to listen to me, I'm afraid.
So yeah, technical thing.
Of course. So yeah, my name's Rachel Evans. I'm a speech and language therapist working at New Cross Hospital in Wolverhampton, and also off camera is my colleague Simon Hussain, who's a neonatal dietitian. So yeah, we're here to share on behalf of ourselves and our colleagues in our NCOT team about a project we've implemented to really think about the MDT management of infants discharged home under the care of our NCOT service. So just some brief background information for you. We are a 26 cot level 3 neonatal unit, and over the course of the past 4 years or so, our embedded allied health professional team has grown, and that includes inpatient SLT and dietetic services, and we also have a really well established strong NCOT service. So over the past 4 years, our AHP team has really driven culture change from a feeding and growth perspective on our neonatal unit, really thinking about an individualised infant feeding journey and viewing tube feeding as a supportive strategy rather than having a drive to remove nasogastric tubes by a certain gestation or prior to discharge home. And that's really grounded in a sort of a neuroprotective approach to facilitate a safe and positive transition to full suck feeding, focusing not just on the current feeding status of that infant, but really thinking about the longer term feeding and growth journey for our babies. So as a consequence of that, the perspective of short-term MG feeding and discharge has changed from previously being the exception to now much more being the norm for many of our babies that go home. So that in turn, as you can see on the graph there, has really led to a significant increase in the number of infants discharged home with short-term tube feeding. And as a consequence of that, our lovely NCOT team, their caseload has really changed over the course of the past few years. So rather than supporting the occasional tube feeder, they've found themselves with a much larger number of babies with feeding tubes at home, often earlier on in their feeding journey. So now we're more actively considering discharge of babies going home with a tube. Some babies are being discharged home earlier to fully establish suck feeding at home. So I should note that there'll be a small number of babies who present as being likely to require longer term tube feeding, and that's not who I'm talking about here. Those babies follow a separate discharge pathway under our community nursing and community AHP services. So the group of babies we're really thinking about are those who present with immature feeding skills, who are expected to move to full suck feeding with increased maturity. So this cohort of babies don't meet the criteria for community SLT and dietetic follow-up. So when we first started in our post as an inpatient service, our teams are really monitoring these babies' growth and feeding via our EPR systems and conversations with families. But what we were finding was that there was a real disparity between the advice that an AHP team are offering compared to the NCOT service. So NCOT's previous role had really been to actively wean tube feeding as quickly as possible. So that continued to be their focus. And now the AHP team were advising families to wait for infants to show tube readiness for full suck feeding. And there was a real push-pull between slowing down versus speeding up, which goes back to really thinking about involving the families and their kind of well-being. So this was resulting in quite difficult conversations between members of the MDT, but more importantly, inconsistent advice being given to parents and actually suboptimal growth and feeding outcomes for the babies. So we identified that there was a real training need, but were unable to act on that immediately due to multiple service constraints, which leads us on to our project. So next slide, please, Sarah. So we established some weekly surveillance meetings that are attended by a representative from each of the 3 specialties. So infants receiving level 2 and 3 NCOT support are discussed at these meetings, and individualised feeding and growth plans are agreed. This includes when to remove NG tubes, close monitoring of growth to support decision making, and might also consider oxygen weaning as part of that process. So discussions are holistic and consider each individual specialty's perspective as well as family and social circumstances. And as an AHP team, it's really helped us appreciate the different dynamics in collaborative decision making when in someone's home versus on the neonatal unit, and some of the challenges our colleagues in NCOT face. Infants and families are often discussed across multiple weeks, and they're discharged from this high-level surveillance when feeding and growth is optimised. And to evaluate our approach, we carried out a survey for all members of staff, and you can see in that little box there that there was a real increase in sort of our understanding of other people's roles, how we all worked, and an increase in our confidence levels in approaching other members of the team for support with growth and feeding. And next slide, please, Sarah. So also qualitatively, feedback has been overwhelmingly positive, and you can see from the word cloud there, comments regarding consistency, collaborative working, and an improvement in knowledge and understanding across all 3 disciplines. The yellow speech bubble is from one of our NCOT nurses who's captured the real heart of what we're aiming to achieve through these meetings, so optimising growth and feeding in a safe and positive manner. And the blue speech bubble is from a parent who really valued the collaborative nature. And for this family, we were actually able to do a couple of joint visits. And that explains there how she felt and how she experienced. And it was a real extension from the care that she received on the unit. And just on a personal note, really, as attending the meetings, they started off as maybe being slightly challenging with maybe some difficult conversations given our different perspectives and management plans. But I'd now say that they're really enjoyable meetings that feel really collaborative and productive, and it's really satisfying to see really beautiful growth charts and reports of positive feeding journeys. Not for all, obviously, but for many of our babies and our families. So in conclusion, establishing these surveillance meetings has been really effective in improving our working relationships across the MDT and facilitating collaborative working. Most importantly for parents, they ensure more consistent advice is given and has allowed for individualised inputs from specialist teams with enhanced provisions such as home visits or other telephone calls as required. And that's in the absence of having a funded designated outreach AHP service. So we spend about an hour and a half each week, and that workload is well contained within that hour and a half. So yeah, that is the end of my presentation. So I'm happy to sort of take any questions or comments from that.
Thank you so much, Rachel and Simon. I think hugely inspirational to hear like a real practical example of that wider MDT working and including everybody in that. I think obviously real benefits for staff, but also really acknowledging that this could have like it's best for the baby and the family, that these things are kind of worked through together. Thank you so much for sharing that. Of course, please do pop any questions in there. I wonder just initially while people are dwelling, just before we finish, are there any kind of particular learnings that you as a team would want to kind of share about kind of for essentially for other people who might want to put something similar in place on the unit? Were there any kind of any surprises or anything in particular that you took away that would be useful to mention in addition to what you've just shared?
I think for us as an inpatient AHP service, we were really mindful that we knew there was a need there that wasn't being met, and we're always really careful, aren't we, to sort of only work within our designated area and what we're funded for. But what we were finding is we were having multiple ad hoc conversations throughout the week about these babies and families anyway. So actually using our time in a much more focused way really helpful. And actually, we haven't needed to do a huge amount of extra training for our NCOT team now, because those collaborative conversations actually have served as our training method. So
Right.
I think if you are, and I know it's difficult, not all, we are a well-funded AHP inpatient service, but not all teams have access to AHPs. But I think if you do approaching your AHP team, if you're able to maybe kind of have some conversations around ways of working. We say it's these surveillance meetings have been a really effective way of sort of managing sort of the babies and the families.
And I think it was more risky, wasn't it, to do these adult conversations? You didn't always, you know, they were sort of passing in the corridor and things, which was more risky for us as health professionals and for the babies and parents as well, because you don't know what you've said from one sort of conversation to the next. So that's why we established a sort of protected time to focus on those conversations and then document them and have everyone agree sort of the same plan.
Yeah, absolutely. Thank you. That's really helpful. Yeah, just that consistency and the focus time, I think, makes a lot of sense.
Yeah.
Thank you. We've had a couple of questions just about criteria around sending babies home and weaning guidelines, and Sarah has kindly signposted to the framework, which I think is probably the most sensible place to go for that information. Yes. I don't know whether anybody has anything else to particularly mention. Sarah, go ahead.
Sorry, I'm going to jump in. This is one of the things that we spent a lot of time talking about within the framework group, because I personally have a big thing about tick boxes, and we spent a lot of time discussing what this should look like, and actually we came up with something called readiness rather than a criteria, because we felt that actually it relied on babies and families being ready to go home. But I'm going to go full circle back to the conversations that we had earlier around actually that planning for discharge should start as soon as you arrive in the unit. And so meeting the NCOT teams, if they are a separate entity from a nursing perspective, starting to have conversations around the knowledge and skills that families will need to care for their baby throughout their neonatal journey, and then to transition to home is part of that process. And again, I've completely alluded to the fact that, you know, telling people the day before they're going that they're going is not really what we should be doing. But the framework supports you around that readiness. So thinking about what services you have available in your transition services, what can your NCOT support if you have one, or what can you do to ensure families are ready. And it will be different, for different units depending on what service you have, but it will be different for different families. Some families, the baby might be ready, but the family is not ready. And we worked really closely with speech and language therapy national professional group to really define what feeding should look like. And so I would please encourage you all to look at the framework, because this is how we will standardise the wording that we're using and also the approaches that we use, because we already know that there's a massive disparity around what good feeding looks like, and people use lots of different criteria, many of which are really not suitable from a neonatal perspective. I'm happy to stick my hand up and say that. So please go back to the framework, and then if you have speech and language therapists, dietitians working in your units, please speak with them. If you don't, and you're in NHS England, please speak with your network AHPs, because they will definitely be able to help you. And if not, I would reach out to your professional organisations. That they're all available. If you just Google them, speech and language therapy, and actually they are all available on BAPM website as well. So I put my plug in for BAPM, and they're signposted to there. So if you need any support, please reach out to all of those colleagues. And I will, Helen, put the link to the framework in the chat now.
I'll also pop it into the email that you'll receive after this as well. But yeah, thank you, Sarah. That's super helpful. I think that hopefully we're literally 2 minutes before the hour is up. I'm super impressed with us to get to this point. So I think hopefully this session has given you some food for thought. We know that there's lots of work still to do, but I think it's really encouraging that so many people are here today, and that there's a real passion for getting this right. So thank you all so much for coming and for engaging and asking questions. I'm just going to share my final slides just because I have a few little QR codes in case that is helpful. So bear with me, sorry. So yes, that is the end of today's session. I want to just say a huge thank you to Steph for sharing her story. that we shared at the beginning of the session, but also to Sarah, to Leslie, to Gaynor, to Rachel, to Simon. There's been a huge group effort to bring this all together, and also have to mention Joe Bennett, who has been really involved in organising today, but unfortunately couldn't attend. So yes, huge team effort. Thank you so much for your time, your expertise. It's really invaluable, and really delighted to have you all here at the session. Thank you, and you all for coming and sparing the time. Yeah, as I say, really hope it's been a useful session, insightful, bit of inspiration for how this can work on your units. We know it's different everywhere, but there's a big community out there that's willing to support you. And of course at Bliss, if there's anything that we can do, please do reach out. We are hoping to run some more webinar sessions. So the QR code that you can see on the left will take you straight to information about that. The QR code you can see on the right is actually a little plug for our brand new family integrated care information for parents. But the way that this was done was initially started with lots of interviews with parents about their experience of a neonatal unit, and it really covers the whole journey, including outreach, I think is touched on in there as well. But it's looking again at some of the themes we've pulled out here today about partnership and about involvement in their baby's care. Lots of different family situations, different dynamics. So I'd really encourage you, if you have some time, which I know many people don't, but if you can spare it and you would really like to hear more from parents, we know that that is really powerful. And there are lots of really amazing positive stories in there about the fantastic work that you do. So it's a huge thank you for continuing to deliver what you deliver and supporting these parents, because it does make such a huge difference to them and their baby. So yeah, thank you so much. I'm going to stop sharing. I really hope to see you all at another event in the near future, but otherwise have a lovely rest of the afternoon. Take care, everybody.